Hello, this is Mrs. Condry. This is Circulation, Part 1 from your Culture and Herbs book. And this is my favorite subject, so I'm very excited. The objectives are that you will outline the structure and physiology of the cardiovascular system. You will be able to explain cardiac output and what affects it. And you will be able to teach patients what a blood pressure actually means. So the heart is the size of your fist, and it's covered by layers. The first layer is the pericardium. That's a tight, tough, fibrous layer with just a small amount of fluid in between the pericardium and the myocardium, which is the thick muscular layer. The endocardium is that inner layer. That's where covering where the valves are and where it contains the blood, and it also covers the large vessels. So the video that the YouTube video that I put a link to should explain the circulation of the deoxygenated blood from the right side of the heart going to the pulmonary, the lungs to get oxygenated. Then the pulmonary veins contain the only oxygenated blood in the body, carries it back into the left atrium, left ventricle, and out through the aorta to the rest of the body. So these valves, when you are listening with your cardiac assessment, you start at the second right intercostal space, and that's for the aortic valve. So the way to remember them is all our apple pies taste mucho or mighty, and Will came up with all potheads try mushrooms. So those are ways to help you remember where and what valves you're listening to. So when you're listening at the right second right intercostal space, and you might hear a murmur, that could mean that the aortic valve is leaking. So that valve here, so the valve isn't closing properly, so the blood could swoosh back and forth. And if you have a big murmur, you might hear it throughout the whole heart, but it would be loudest over the aortic area. If you have a mitral, if you hear a sound, a murmur over the mitral area, which is underneath the midclavicular line, like underneath the nipple, you'll probably hear it if it's a large murmur throughout the whole heart, but you'll hear it loudest in that apex, and so that would mean that it's a mitral murmur. But if you hear a murmur, I'm happy that you actually can identify a murmur. You don't have to be a cardiologist and say it's a mid-systolic, diastolic murmur. No, just recognize that there's a murmur there. Patients usually know if they have a murmur or not, and if they've never heard that, then that's something you do need to notify the physician when they come in, although it's usually not an emergency. So then our heart is a muscle, so even though its job is to squeeze and pump blood throughout the body, it needs oxygen as well because it's a muscle. So there are arteries on the outside of the heart to supply oxygen. And the way you remember it is it's the patient's left side is the left anterior descending, and the right side is the right coronary artery. So it's the patient's right side and left side. The circumflex goes to the back of the heart, and if there's a blockage in the left anterior descending, which we call it LAD, that's the most dangerous. It's called a widowmaker because our left ventricle is our muscle of the biggest muscle of the heart, because its job is to squeeze that oxygenated blood through the rest of our body. So we need that pump to work in order to have cardiac output. So when we're listening to the heart and it's the lub-dub, the beginning of systole, which is where it pumps, where it squeezes, the beginning of the systole, which is lub, is the actual closure of the tricuspid and mitral valves, and that's what you're hearing, and that's the squeezing. Diastole is when it relaxes. The heart is relaxed, and that helps it get the blood, both from the deoxygenated blood from the body and the oxygenated blood from the lungs. So diastole is a longer, more passive process to help it, to give it longer to collect the blood. Systole is quicker. Systole is where it squeezes and the blood gets distributed where it needs to be distributed to. So that dub sound is the beginning of diastole, which is the relaxation phase, and that's the closure of the aortic and pulmonic valves. So the cardiac muscle also has electricity in order to create that contraction. Our cardiac muscle contracts in response to those electrical impulses. And it has automaticity, which means that the heart muscle has the ability to generate electrical impulses independent of the nervous system. So the nervous system does have an effect on the heart rate, but our heart muscle has intrinsic protection that gives it the ability to contract or send impulses so that it can contract in order for us to continue having cardiac output. So our SA node, which is here in the right atrium, is the main pacemaker of the heart. And it sends impulses to the rest of the heart 60 to 100 times a minute. So it sends it over to the left atrium, goes down to the AV node, through the bundle branches, and through the Purkinje fibers. So that impulse is seen on a telemetry. That telemetry doesn't tell us that it's contracting. That telemetry only tells us that the impulse is being sent. So when we see a P wave, which is a electricity, that's just telling us that it's depolarizing the atrium, and the depolarization is what creates the contraction. So if our SA node fails, we have an AV node backup, and that is the SA node has an intrinsic rate of 60 to 100. The AV node is slower, and that rate might be, I think it's 50 to 70. And then the lower the heart is, like down here, the intrinsic rate might be 20, which of course doesn't give good cardiac output. So you won't have telemetry or the ability to read cardiac electricity until the second semester of your last year. So what is cardiac output? Cardiac output is the amount of blood that's pumped by our ventricles in 1 minute. So cardiac output is our heart rate times our stroke volume, and that over 1 minute is what our cardiac output. So our normal cardiac output is 4 to 8 liters per minute. And if you have less than that, you have poor tissue perfusion. Our cardiac output indicates how well that heart pump is working. And like I just said, our decreased cardiac output equals poor tissue perfusion. So in order to increase our cardiac output, we need to increase our stroke volume, or increase our heart rate, or increase both. So that stroke volume is affected by the contractility of that cardiac muscle, and that cardiac muscle is also affected by the autonomic nervous system and some drugs. And there are drugs, inotropic drugs increase contractility, and negative inotropic drugs decrease our contractility. So I'm not going to expect you to know which drugs are which at this point, but when you take pharm in the fall, you will need to be able to differentiate which drug is an inotrope versus a negative inotrope. So then we move to preload and afterload. Preload is the volume that's coming into the ventricles, and it's also called end diastolic pressure. When we do a cardiac catheterization, they do measure that end diastolic pressure. And so if you have a large volume, such as hypervolemia, if you have too much fluid on board, your preload is going to be higher. And if your cardiac valves are regurgitating, so regurgitation means that the cardiac valves are supposed to close shut, but if they don't close shut, so say they're sclerosed and they don't close and they're open that much, so when the heart ventricles contract and squeeze, instead of the blood staying in where it's supposed to stay in, it squishes back and forth between the atrium and the ventricle. And so that it can increase the preload. The afterload is that resistance that the left ventricle must overcome to circulate that blood. So remember I said that left ventricle is very important. It needs to be strong in order to get good cardiac output. So if it has higher resistance, such as hypertension, which is high blood pressure, the afterload is higher. And if you have vasoconstriction, so instead of the vessels being open like this, they're really tight, that increases afterload. So then there's another term for preload, and that's the Frank-Starling law of the heart. And the Frank-Starling law, I'm sure, was created by Frank Starling. And his law says that the length of the ventricular muscle fibers, as they stretch at the end of our relaxation phase, it directly affects the strength or force of the contraction. So if you have a firm muscle that doesn't stretch, then our preload is going to be higher. It will affect our afterload. So when you exercise, so you're running, and so it increases our pulse because we need to have more oxygen. And so when you increase the pulse, you're also increasing that stroke volume. And so then our cardiac output increases. But if your heart is not strong, it may not be able to keep up with that demand. And so then you might have some pain in your chest because you are not able to keep up with that demand. So again, I want to repeat to make sure you look at the videos about the oxygenated versus the deoxygenated blood through the body. Remember from our fluid and electrolyte lecture, that arteries have thicker walls and it has higher pressure. So it has higher pressure so that the fluids, water, oxygen, red blood cells can flow out because we have higher pressure in our arteries so that it can flow out. And then especially through the capillaries, because the capillaries have a thin layer, very thin layer, and that allows those gases and molecules to diffuse between the blood and the tissues. But then veins have lower pressure so that the stuff can come right back in. And valves are in veins right here, and that prevents the blood from flowing backwards because we have thinner walls in our veins, and we have skeletal muscles that assist that blood movement. But so if you have good valves, the blood doesn't leak back. But varicose veins are incompetent valves. So instead of that valve closing tightly, where's my mouse? Okay, the valve stays partly open, so the blood pools, and that's what you see in a varicose vein are incompetent valves because they aren't closing properly, so blood just kind of pools there. So that's why we recommend that people wear elastic stockings to help keep that blood back in the vessel instead of leaking out. So now we're going to turn to blood pressure. I know you've talked about blood pressure many times, but I want you to understand that blood pressure, the top number, systolic, relates to systole. Systole is when the heart contracts. So systolic pressure is, it indicates the force used when our heart contracts and pumps blood. And diastole, related to diastolic pressure, indicates the force used when your heart relaxes and fills with blood. So if you have if your vessels never relax, if the pressure is always high, it's harder for your blood to circulate through your body. Your heart has to work harder to go against all that resistance, and so then the patient needs an antihypertensive to relax those vessels so it doesn't have to work so hard. When it has to work hard, that can create heart disease. Now we're going to turn to blood. Blood has the serum. Red blood cells carry our oxygen. We have platelets that create allow clumping of platelets to prevent clotting. To prevent bleeding. It creates clotting. White blood cells fight infections. So if you have a low hemoglobin, you have less oxygen delivered to your tissues, which means you can be fatigued. So when you put a pulse oximeter on, that doesn't give you an indication of how many red blood cells are in the blood. It just gives an indication of how much of the hemoglobin that's in the blood is attached to the oxygen. So if you get a reading of 96%, that means 96% of the red blood cells have oxygen attached to them. That sounds great. But if you don't have many red blood cells floating around in there, you're still going to have less oxygen delivered to the tissue. And that's why we do blood draws to see what their hemoglobin and hematocrit is. So let's review the structure and physiology of the cardiovascular system. I'm going to make you dizzy and go back. The heart is a muscle, has many layers. Deoxygenated blood comes from the inferior vena cava, the superior vena cava into the right atrium, through the tricuspid valve, out to from the right ventricle out through the pulmonic valve to get oxygenated from the lungs, comes back through the pulmonary veins, into the left atrium through the mitral valve, into the left ventricle through the aortic valve, and out to the rest of the body. Our heart needs oxygen, and so that oxygen is supplied by these arteries surrounding the heart. Systole is when it squeezes, diastole is when it fills. Lub-dub is the sound is the sound of closing, the tricuspid and mitral valves closing. So in this picture, it doesn't show them closing because it's showing the actual systole. Well, because the sound we're hearing is just the beginning of systole. And the sound of diastole is the beginning of diastole, and that's where it closes the aortic and pulmonic valves. So that's our lub-dub. Cardiac conduction is our cardiac muscle contracts in response to electrical impulses, and our SA node is the primary pacemaker of the heart. Impulses come from the SA node down to the AV node through the bundled branches and Purkinje fibers. That depolarizes, which creates that muscle contraction. Our cardiac output is the amount of blood pumped by the ventricles in 1 minute. And our cardiac output is normally 4 to 8 liters per minute. So if you have less than that, you have poor tissue perfusion. The patient doesn't look good. And our heart rate is affected by our blood pressure, by the autonomic nervous system, hormones, and medications. Preload is the volume coming into the ventricles. Afterload is the resistance that left ventricle must overcome to circulate that blood. Frank Starling law says that the length of the ventricular muscles fibers stretch at the end of that relaxation phase directly affects the strength or force of the contraction. Our blood vessels consist of arteries with high pressure, capillaries with just a thin layer, veins with low pressure. Blood pressure, the systolic, the top number is the force used when our heart contracts, systole. The bottom number is when it relaxes, diastole. And our blood consists of red blood cells which bind to the oxygen. And that's it for this lecture. I will see you in part 2.